Senate.
This is the California.
Good morning, everyone. We're going to go ahead and get started. Let me introduce myself. I'm State Senator Ed Hernandez. I represent the 22nd Senate District, also chair of the Senate Health Committee. This is a informational hearing on Mylan EpiPen and drug pricing. Today is September 29th. It's approximately 10:41 in the a.m. Couple of housekeeping comments for those of you in the audience. I'd appreciate if you do have cell phones, if you could silence them or turn them off so they don't go off during the hearing. Secondly, I'd like to take this opportunity to thank the LA Law Library for opening up the venue here. It's a beautiful venue. Also, the services that they provide are incredible to the consumer, which is information on legal services to the residents here in the LA County. So I would encourage everyone to use these services. Also, we have a series of panelists that are going to be up speaking on it. Just for everyone's information, we did ask the CEO of Mylan, and we invited them. They chose not to attend today. We even invited anybody from a representative to see if they make any comments with regard to any of the questions we have. So let me just make a couple opening remarks. I have with me Senator Hall, and maybe if he would like to make some as well. So, you know, as chair of the Senate Health Committee, there's three things that are of the utmost importance to me. One being that we successfully implement the Affordable Care Act, which California has done an incredible job and taken a leadership role in its implementation. The second thing is to making sure that every single resident in this state from all parts have access to health care, even the poorest in the most rural and in the inner city. But I think the one that's just as important is how do we control healthcare cost, period. We've had a series of hearings over the last few years, from hospital costs, provider fees, to drug medications. And the reason why we've had hearings, especially with regard to controlling cost, is the consumer is asking that we allow them to have as low a possible premium. We are now post-Affordable Care Act, and we are requiring that every resident in this state and in this country purchase health insurance. The number one concern from the consumer is the cost of their premium. Even with subsidies, we have residents that are struggling to pay premiums, and yet they're required to buy health insurance. Well, one of the reasons for skyrocketing increases in our health premiums is because of pharmaceutical drugs. Now, keep in mind, we are going to be talking about Mylan today, but Mylan is just one example of drug companies that continue to raise prices. And it's not new innovative drugs, it's existing drugs. It's existing drugs that just by altering the chemical makeup of it, that they continue to raise in price. The dilemma that we have is that there's patenting issues involved where they have the ability to monopolize the market and continue to raise drug prices. And at some times they'll even offer rebates, discounts to the consumer, but at the end of the day, that may help the consumer initially, but the insurance company still has to pay the difference, and that insurance company then has to pass that on to the consumer. So we all lose in the form of higher premiums. And if it's not in the private sector or if it's not in Covered California, then it's also in state government, whether it's CalPERS, whether it's the prison systems, or whether it's our Medi-Cal system. The taxpayers will lose by increasing the cost of health care. Just last year, I introduced a very modest bill, SB 1010, which was heavily lobbied. And the reason why is because the pharmaceutical industry does not want to change the way they do business in this state or in this country. And for them, business as usual is making record profits. So this is the reason why we're going to have this hearing today to highlight one particular company that's gone far further than what they should have with regard to profits and, more importantly, the costs that are passed on to the consumer. But we're going to do a series of hearings just in pharma in general and the practices that go on with how they introduce legislation to various states to mandate certain products, but yet the consumer prices continue to go up on prescription medications. So I want to thank everyone who's here, all the panelists who will be speaking shortly. I'd like to turn it over to my colleague to my right, that's Senator Isidore Hall. I'd like to see if he'd like to make any opening comments.
Yes, thank you, Mr. Chair, Senator Hernandez, and thank you for bringing this issue to fore. There is no question that we are struggling. This is post-Affordable Care Act time, and yet we are still struggling trying to make sure that the folks here in California have access to health care. We have health care deserts still in the lower socioeconomic communities where people of color cannot even get a doctor to provide services because of the reduced reimbursement rates of the Affordable Care Act. And then at a time when there is such a crisis, we have a certain industry or particularly company that's putting pricing over health, which further pushes particularly the lower socioeconomic communities and the disenfranchised to the back of the line. I myself particularly have allergic reactions, and I use an EpiPen. And it is unconscionable to think that one in my community that can barely afford to pay rent would have to pay $500 or $600 for a device to save their life, when in any other term, the device would cost $50 to $60. And so I'm standing here with my colleague, Dr. Hernandez, to call and to bring this issue to light, to do the necessary work we have to do to make sure we cure this problem, and also to call on the federal government to bring an investigation and to this company, and to perhaps do whatever they have to do to make sure that folks in my community throughout California and throughout this nation, particularly the disenfranchised, are able to afford such a device to be able to save their life. This is ridiculous. I'm honored that my colleague, Dr. Hernandez, has brought this issue to fore, and we hope that our colleagues here today and those in the industry will help better our understanding and knowledge as it relates to this issue. But pricing over health is unacceptable, and especially here in California. Thank you.
Thank you, Senator Hall. We're going to now move on to our first panelist. They're patients and families and the impact and coping. We have a young lady, Angela Chen, who does have food allergies, and for your information, she's a constituent of mine. She first approached me several years ago with some incredible ideas. This is a very bright and young woman who is going to do great things when she gets out of college, and she'll probably take my job someday. Welcome, Angela.
Thank you, Chair of the Senate Committee on Health, Senator Hernandez. I'm really happy to be here to share my experiences with food allergies and using the EpiPen. So just a little bit about myself and my food allergies. So personally, I was diagnosed since I was a few months old. I'm currently allergic to all nuts, tree nuts, some seeds, mango, and kiwi, but previously I was allergic to a lot more items. And I'm anaphylactic to all nuts, which means that I may have a life-threatening reaction when I'm in contact with trace amounts of nuts. And so that's why the EpiPen is so crucial to me and to all the other people who have food allergies that threaten their lives. And so I'm going to talk a little about my relationship with the EpiPen, how it's useful to me, if I've used it in my life. So I've used the EpiPen once, and that was when I was around 11. I was at a restaurant and ate pesto pasta, and I had pine nuts, and I was allergic. So I had to use both of the auto injectors in the twin pack, and luckily, I did bring it with me. And so I've actually had a couple more life-threatening situations this past summer when I traveled to Yale, stayed there for a summer camp, and if I didn't have my EpiPen, I probably wouldn't be able to get help that quickly, because usually a reaction for me takes only a few seconds to kind of crescendo into me being not able to breathe. And so I usually have 4 sets of twin packs at all times. And that includes one that I carry in myself, one that I have with a school nurse at my high school, and one that I have in a designated location at home, and then one just for backup, because sometimes EpiPens expire within like a year, and I don't really check them every single day, so it's always good to have backups. And every time I travel, I have to carry at least 2 twin packs or 3, because there's an increased risk when you travel, and you might lose it on your way. It's hard to purchase elsewhere when you're unfamiliar with the location, and it's also harder to get help. So I have to have quite a few EpiPens, and that does amount to more cost on my family in terms of purchasing these auto injectors. And so the prices have definitely impacted my family, though not as much as perhaps other families, because of the coupons or the insurance paying for part of it. But still, even though the price of the EpiPens may be going up a large amount, my family doesn't really have a choice whether we want to purchase it or not. So Mylan can increase the prices a huge amount, but we just have to drag ourselves to the pharmacy and still buy it, because it's so crucial. And sometimes we do get coupons from, say, our doctor, but it varies, and we're not really sure what we're going to pay each time we walk into the pharmacy, so we have no idea. And so currently, for me personally, I have to spend at least, I would say, like around $250 per year, and that's if I have all the coupons possible. And sometimes that's not the case. Like last time before I went travel to Yale, I had to pay the full price because I didn't have the coupon, and that was really sad, but I had to have the EpiPen because I was traveling. So the most, I guess, frustrating thing for me and my family, not only is the price hike, but also the fact that it's really unpredictable. The prices are changing, the coupons are changing, and really for us, it's not really transparent what's going on. It's kind of disturbing, because I know that I'll have to rely on this device for the rest of my life. And so each year it's going to be at least 4 twin packs, and you multiply that by, I don't know, like 75 years. It's a lot. And so we just hope that Mylan would be able to recognize that, and to be able to address it, to make sure that the prices are reliable, reasonable, and that they can see from the perspective of their consumers, and that these devices are very, very crucial to their well-being. Thank you.
Thank you. We're going to now move on to Kim and Kendall Hollinger, food allergy advocates. We can just move the mic over to the middle, or welcome.
Hi. So my name is Kendall, as he said, and I am anaphylactic to 95% of all food. So I have a feeding tube in my stomach. I was born that way. I can't remember a time, as Angela said, where there wasn't an EpiPen in probably a little circle radius around me at all times. In my mom's backpack, in my backpack, on my dad, on my family members. There was always EpiPens everywhere, because we never knew when I was going to drop into anaphylaxis, and it happened 8 times so far in my life. I've had to use my EpiPen 8 times, and each time was near-death experiences. And because of that, I felt it was really important to speak today, not only about my own experiences, but because of my own experiences, from a child's perspective and a teenager's perspective of what it's like going about life like this. And I think it's important to try to help the pharmaceutical company understand what that is like, and them to try to imagine what it would be like if that was their family member or someone that they loved trying to struggle and go about this disease and having to have the auto-injector. I had my first anaphylactic reaction at 5 years old, and I vividly remember most of it. As some of you may know, medical PTSD is a very real thing. And because of that, this is not, I guess that's what's the most important thing to help people understand, is this is not just me. I'm just an example. There are 15 million Americans with food allergies, and I think 4 million of that are children. And so from a child's perspective, you're taught to rely on the EpiPen, but you're also kind of afraid of it. And I remember my first reaction, I specifically, to try to help not to share in the sadness of what it's like to live with this disease, but to try to help people understand the realness of how scary it can be, is I basically went into anaphylactic shock from just being in a rental car, that there were somehow peanuts on the ground in our peanut shells. I didn't know. We'd never used a rental car before. So just by being in that car for maybe a couple minutes on a drive home, I then got home and started to bark like a seal, lose consciousness, and basically my blood pressure tanked, and I went into anaphylactic shock for the first time. And my mom was on the phone with my allergist at the same time as holding the EpiPen in her hand, and I remember specifically looking at my mom and saying, "Mommy, please don't let me die." And this is not something that is rare. This is every kid living with this disease. This is every teenager going about school trying to sometimes hide it because they're embarrassed of it, or because they feel that yes, it is a life-saving device, but some people are afraid to use it. And so that's why advocacy about epinephrine is so important. But when the cost is so high, it's nearly impossible to continue to advocate for people to get them. There are a lot of coupons and things that have been available for people, but it gets to a point where sometimes that's not an option. And for most families, I know for mine, growing up, that was before we would pay our rent, before we would pay our electric bills, anything, the very first bill that got paid was the medical bills, because I had to have epinephrine. I had to have it on me, and that's not new. That's every person with food allergies. Without it, you're putting yourself at risk, and most ambulances, I know California, I think, is one of the states that we do require ambulances to have epinephrine, but in a lot of states, that's not the case. And so if you don't get epinephrine in at least a couple minute, for me it's seconds, radius of that reaction, your throat will close and you will slowly suffocate, and eventually your heart will stop. And that is why it is so important for EpiPens to be accessible to every single person, regardless of the economy, regardless of where they live, regardless of their situation. It needs to be affordable, because without it, their life's on the line. And I guess my question to the pharmaceutical company would just be, if it was your family member, or if it was you that was living with this disease, would it change your mind about the pricing that you are continuing to hike to higher and higher rates? Would that change your mind if you knew that it was someone that you love's life on the line every day, or the lives that have already been lost due to lack of epinephrine, whether it be because of the price, I'm not sure, or just because of people not having it in time? It's a real epidemic, it's a real thing, and I would just hope that, coming from the perspective of someone actually living it, they would consider lowering the prices and making them affordable.
Thank you.
I'm Kim Hollinger. I'm Kendall's mom. Kendall's always been allergic. It's day 2 of life, she stopped breathing. Her first memory of an anaphylactic reaction was at 5, but it had happened before that. The struggle as a parent of one of these children is the equivalent of not having it is basically a gun to your child's head. If you do not have it, your child will die. You can't, there's no way around it. And if it's not affordable and we don't figure out a way to make it affordable, there are families that will go without. And I would say 80% of anaphylactic reactions, and that's just a guess on my part as a mom, they don't have time. There's no time for them to wait for an ambulance and then get them to the hospital, because the truth is, in anaphylaxis, the ambulance can't do anything for you other than give you oxygen. You can't trach somebody, you can't breathe for them because the airway is swollen shut. And shortly after your airway swells shut, your heart stops. And we've been through that with her. It's terrifying as a parent. Your kid's blue, they're lifeless, and you're just, in our case, praying to God that, Lord, let them make this, help us through this. And sometimes it takes more than one injector. And I personally I've used an EpiPen on 2 strangers before because they didn't have them. Someone's child was dying. I came upon a situation where they needed help. I had permission from the parent first, and I injected the child. Happened to another older woman. This is going to happen more and more, but in saying that, it's not the answer because I have to have them too. So if I don't have them, how can I save myself or my daughter? What I would like all pharmaceutical companies, not just Mylan, because it's not just about Mylan. The truth is there was another company, their price was $100 more, but we're not talking about them because they're out of business now. It's not just a Mylan thing, it's across the board. If you can afford to pay the kind of salaries you're all making, I think there's a way to make this drug cost a lot less.
Thank you. And we will now move to Beth Capel, Health Access California.
Mr. Chair and members, Beth Capel on behalf of Health Access California. You've just heard far better than I can explain what we really mean when we say something is a life-saving medication. This is a drug that literally saves people's lives. There are other drugs that just as much literally save people's lives. You know, I'm just old enough to remember the end of the polio epidemics, and I remember very well walking with my folks and my brothers over to the local neighborhood school to eat the sugar cubes to make sure that no one in our family ever faced death or disability from polio. Those vaccines were affordable. They were affordable enough that we have, through a major public health effort, eradicated polio in this country and in many others. And that was possible because the cost of the vaccine was modest. The contrast of the polio vaccine with the business strategy of whether it's Mylan with the EpiPen or Gilead with the Hep C drug is quite stark. Mylan, in its letter to you and in their testimony to Congress, talked about the importance of expanding access, as indeed Kendall and Kim and Angela have. But how much more could we expand access to the EpiPen if it costs $3 or $30 as opposed to $600? Why can't we treat every Californian, every American who has hepatitis C, eliminating the reservoir of infection, something that we do with tuberculosis? We can't because the drugs to cure hepatitis C cost tens of thousands of dollars, not tens or hundreds of dollars. You know, Mylan has repeatedly raised their prices, claiming there is no impact on consumers. Well, you've just heard from a number of consumers that that's not true. Consumers pay for their health care. They pay, even if we have health insurance, we pay in terms of ever-escalating copays, we pay in terms of deductibles, we pay an ever higher share of premiums. We pay when our wages do not go up because employers pay more for health care. Just a few facts to help frame this. Prescription drugs are now almost 20% of the cost of premiums for those of us under age 65. 20%. Health insurance premiums paid by employers in California have gone up 216% since 2002, 5 times the rate of inflation. That means that almost $1,400 of the almost $7,000 paid for employee-only coverage is paid for prescription drugs. Deductibles, which were once uncommon in California, have also climbed. More than 1 in 5 Californians now have deductibles over $1,000. 3 and 4 tier drug plans, once unheard of, are now routine. Drug copays have climbed, and coinsurance of 10 and 20%, once non-existent in California, is now commonplace, particularly for drugs that cost more than $600. And that includes not only EpiPen, but drugs for multiple sclerosis, rheumatoid arthritis, AIDS, HIV, and a long list of other conditions. And all of this spending on healthcare comes directly out of wages, or so the economists tell us. So who pays? We pay. We all pay. And a very different approach to drug pricing, one in which, as usually we think that when more people use something, the price will come down. This seems to be the only area in economics where the more people need something, the more the price goes up. It doesn't make very much sense. And as you said, Mr. Chair, taxpayers pay more as well, and those are, it's important to look at the costs in Medi-Cal, where we understand it has doubled, and as well the costs to our schools, where so many of them stock it now. So, thank you.
Thank you. At this point, we will open up the question to the panelists. Does Senator Hall have any questions at all?
Yeah, I just want to thank Kendall for your testimony today, and you as well, Angela. I know it is not easy to talk about a condition such as this. Oftentimes the embarrassment of explaining a condition, being treated differently is also a factor. Having to carry a device and explain what the device is an issue. I know, I do it every single day. I have to carry a black bag as a male, and people say, why are you carrying a bag? It's because I've got stuff in there just in case I need to save my life. It is not an easy thing. And when you have this reaction, and it just takes seconds, and before you know it, your throat is tightening, you feel cracking in your throat, your eyes are getting big, you can't breathe, and then it's exacerbated if you get nervous. Once you get nervous, it brings it on even more. That is not a pleasant feeling, and wondering if or not you're gonna die. It is not a pleasant feeling. And so you both having to have dealt with this your entire life, since I was 8 years old, I commend your advocacy, and thank you for being an advocate in a world where folks really don't understand. And it's interesting, Mr. Chair, on Mylan's letter, they have, in their logo, it says Mylan, and then it says, seeing is believing, right here. And how ironic, Mr. Chair, it says Mylan, then seeing is believing. We believe Mylan. We believe that they don't care about the folks in our community that are suffering, that cannot afford such a drug. You have to be rich in order to live, because no one else is going to be able to provide and be able to afford this drug that's going to save lives, particularly in lower socioeconomic communities. So, Mr. Chair, I just wanted to say thank you to Kendall and Angela for advocating and giving voice to power and giving other folks an opportunity of hope to be able to come forward and speak against companies that are taking advantage of our young folks and adults in our community. So again, thank you.
Thank you, Senator Hall. Also, I'd like to just reiterate what the Senator said. I'd like to thank both the advocates and the parent. Just a couple comments. I know there was some reference made to coupons, discounts. I think Angela May said that she wasn't sure what the price would be when she went to the pharmacist. Let me just kind of reiterate the playbook that most pharmaceutical companies do. They will provide this to the consumer because it's the consumer that complains. Well, if the consumer gets a rebate, it kind of quiets them temporarily because they don't pay as much when they go to the pharmacy. And in Angela's case, she even said, I didn't know what that was going to be depending on if or not I had a coupon. But here's the thing, somebody does pay. And it's the consumer and it's the taxpayer, because that price is still passed on to the insurance company, which passes on to all of us in the form of a ratepayer. So there is a cost to this medication. And the other thing I think Ms. Capel mentioned, for Gilead, for example, how expensive it is. Well, guess what? I think there's a social responsibility that we have in healthcare that, okay, rather than charging a lot for a few patients, charge less, still make money, but yet eradicate hepatitis C, Make it affordable. Make it affordable. And I think that's the big difference. And I think the one that's most striking, especially the comment that was made today, and being a parent as well, is when Kendall Hollinger said, when she heard her daughter say, "Mommy, please don't let me die." I mean, to me, that's, I think, the essence of what this hearing is about. And what we need to get from this hearing is to find out, how do we make sure that consumers in this state, all consumers, whether you can afford it or not, have access to medications and are affordable. So with that, I'd like to just thank you, all of you. We're going to now move on to the next panel. That's the provider's perspective. If we can have staff come up and change the placards, please. We have Cynthia Owens, MED RN, Coordinator of Student Support, Credentialed School Nurse, Murrieta Valley Unified School District. We have Maria Garcia Loret, MD, Division of Pediatric Allergy, Immunology, and Rheumatology, Department of Pediatrics at UCLA School of Medicine. Well, good morning. We're going to go ahead and start off with the first presenter. That's Kathy Owen, MED RN. If you could please proceed, and thank you and welcome.
Good morning.
Push the button.
Push. Is that working? There. Good morning. Thank you so much for giving me the opportunity to speak. I am a credentialed school nurse as well as coordinator of health services for Murrieta School District, but I'm also a national epinephrine resource school nurse, and I've spoken both statewide and nationally on food allergies and advocated for stock epinephrine. I'm here to speak on behalf of all the school children in California. I'm not an individual with food allergies, and I have no family member with food allergies. However, several years ago, there was a student came into the office who did not have a history of any anaphylaxis, but presented with anaphylaxis. We, of course, called 911. But unfortunately, paramedics did not arrive, and he declined quite rapidly. So I had to make a life and death decision, and I chose to use someone else's EpiPen. I ended up risking my license, but there was no other choice to save his life. So because of that, I became very involved and helped advocate for stock epinephrine, and we had a bill passed in 2001 that allowed schools to stock it, but it did not require it. And even at that time, a lot of schools were hesitant to stock it because of the cost and the fact that because it wasn't mandated was their liability. And of course, we've learned so much in those subsequent years. That was 2001, that obviously that epinephrine can't hurt anyone, and if they're having a breathing emergency, they need it. And that it has to be given immediately, as we heard from our individuals with it. If they don't have that medication on them, immediately death can occur. So in 2014, Senator Huff was able to pass a bill, so we mandated in California that there's stock epinephrine. So you would assume that, okay, everybody's safe. Children in school are now safe. But unfortunately, the rising cost of the EpiPen has had a dramatic impact, and that's why I'm here to speak. While we very much appreciate the EpiPen program for school, in California, in order to have stock epi, even though it's required, you have to have a credential. There's 3 components of the law. You have to have a credentialed school nurse that is willing to train and supervise. You must have a physician who writes the orders, and there are many districts who we know don't have school nurses and have difficulty finding a physician. And 3, someone has to be willing to volunteer to give it. Quite differently with a child that has an individual prescription. California Ed Code specifically states that school districts must delegate individuals to be trained and ready to act on their behalf. So while we have stock epi that may be sitting in the health office, and we've asked for volunteers to be willing to be trained, and it might be, the night custodian, or it could be, the secretary. She certainly is not going to be the one that's going to be with that child, near that child, and ready to react. I've seen in our schools, we've had upwards to 30 to 40 stock epinephrine individual orders provided by parents for their children. That number has dropped off dramatically because they can't afford it. And they're relying on the school. Well, the school will protect my child. And we know that in that same time frame, we've seen food allergies, and the severity of the reactions of food allergies climb dramatically. Tragically, there was a young girl in Virginia who parent could not afford her EpiPen. She had a reaction at school. The mother, when they called her, she pleaded, please, someone give her EpiPen. She needs epinephrine. And she died because they did not, or, I don't know if they didn't have stock epi. I know they do now, but children have to have their medication, not in the stock cabinet in the office, but those who have identified food allergies. The stock epi program is for that child that we know 20 to 25% of people who have a reaction have their first reaction at school. So there's a component of population out there that they don't even know they're identified. But we also know that those who have identified in anaphylaxis type reactions need to have individual staff trained. They need to have their medication with them. That law provides that to be, whether or not it's in the classroom, on their person, on the field trip, in the bus. That stock epi is not going with those children. And we have kids in our schools. We take them from the parents, and we have them probably half their waking hours, and we're responsible to take care of them. And so for the cost of this medication to be so exorbitant, and for me to know that there's children out there that are at risk for dying, is why I'm here speaking. I also, because I've been involved with it for so long, the packaging and the delivery system of the medication has changed minimally. From when I first, was using an EpiPen back in 1997 to today, the only change is it used to be a round container, now it's somewhat of an oblong, and it does have, when you automatically eject it, there is a needle cover that pops over so that there's not risk of accidental needle stick. Other than that, the dosing, nothing has changed. So there's no explanation why, it's automatic. You can understand why the price would go up. They've changed the components of it. It's been 0.3 milligrams or 0.15 since I've been, like I said, since at least 1997. So for the children in our state of California, we have got to do something because these kids are at risk if they don't have their individual orders.
Thank you very much. We're going to now move on to Maria Garcia Lorette, MD, Division of Pediatric Allergy, Immunology, and Rheumatology, Department of Pediatrics, UCLA. Welcome.
Hi,
Please proceed.
thank you for inviting me. I have to say, I was touched by hearing, the stories of the patients. There are many of the stories that my patients share with me. I have to tell you, I've been treating children with food allergies for about 15 years. Food allergy is the main cause of anaphylaxis in children, although, it goes now to adults. Some of my children patients now, they are adults. And I have to, sometimes I ironically say I'm one of the people to blame maybe of what we're suffering today. Our group was the first to establish a food allergy awareness days in Los Angeles. Believe it or not, in 2005, this was a disease, and for our adolescent patients, probably this will resonate with them. This is an absolutely increasing epidemic. It's a disease that affects 4 or 5 million children under 5. It's not going anywhere but up. My practice today is about 80% kids with food allergies. There isn't a single day in which I don't prescribe 1 or 2 or 3 epinephrines. There isn't a single day in which I sit in front of a family and they say, well, you got a food allergy, but we've got this. I can say, part of a lot of what we do today in education is teach kids and parents and school nurses, how to dodge anaphylaxis, because that's one of the things, is prevention. And then when you find it, recognize it, and treat it full frontal. And that, recognize it. One part of my job over the years is actually to teach patients and their families how to recognize the beginning of an anaphylactic reaction. Because, one of my pet peeves was, people use the epinephrine too late. You don't have to be passing out before you use it. In fact, I've been an advocate to use more sooner, because that would save, aggravation, healthcare costs, and anaphylaxis in a group of patients has this way of coming back within a few hours. So the sooner, not only, you get better sooner, but, there's something that we call the delayed reaction, that you think, oh, well, I'm good. and then 6 hours later, boom, it's back on. So that's the idea behind these like 2 epinephrines that come in the pack, because in some patients 1 epi is not enough. You have to do what we call a back-to-back, and B, in some patients it comes back a few hours later. So every single day in my clinic, I spend substantial amount of time. Okay, these are your food allergies. This is what will happen. This is the worst case scenario. You are prepared. Empowering patients. They say, okay, as long as you have your epinephrine auto-injector, you're going to be good. In the last year or so, people, it's almost like I'm creating now more anxiety than help, because they say, you've got this. And now they come to me and they say, no, I don't have it. Because I went to, this pharmacy and this is what it costs, and this pharmacy and this is what it costs. So it's interesting when people talk about coupons. I'm a provider, and sometimes it seems in my office I'm like the Sunday LA Times. I have to start finding out where's the coupon? Where's the coupon for this medicine and this coupon for this medicine? Why? Why people have to do coupons? It doesn't make sense to me. That epinephrine and the asthma. I treat a lot of patients with asthma. The asthma people, all of them have a coupon, but just put it in where it should, Why do I tell them, well, let me just see what I can give you, because I don't have a coupon for this. This is my reality. I spend substantial amount of time in this kind of nonsense. It is ironic that what I felt over the last 15 years that I've seen patients, following patients with food allergies, what I thought it was like the greatest thing to empower patients, how to manage their food allergies, how to treat when they have an acute reaction. Then now the downfall is that we tell them you've got it, and now we have to tell them, no, you don't. Why this medicine, as you say, the improvements have been minimal. Went from $100 since I did my first food allergy awareness day in 2007 to the second one that was in 2014, went from $100 to $600. It's something that it definitely doesn't make sense to me. But unfortunately, I don't have options, because it is a monopoly. The treatment for a patient with a food allergy is avoided, and when you find it, treat it. There is no option. There was a couple of comes and goes of medicine. There was a Twinject that indeed was taken out of the market a few years ago, maybe 2 or 3 years ago, that patients didn't like much because, it was a little bit more awkward, the injection method. There was this medicine that came in 2014 that was actually better in terms of the device, because it was good and more practical to take. It's a little kind of iPhones, and that went into the market, and less than a year later was removed. So there is nothing else. The alternative of telling patients to take a syringe, an insulin syringe, I can do it, we can do it, but that is definitely not a good option, and it carries a lot of risk of misfiring. So we are 15 years later, much more food allergy awareness, much more research in food allergy coming out of the NIH. For the 2 young ladies that are in the audience, for the one that said that she'll need the EpiPen for 75 years, I promise you won't. I promise you we'll cure you before you have grandchildren. But in the meantime, we need good access. We need something that, again, that makes sense.
Thank you. Any questions from Senator Hall?
Yes, Dr. Lorette?
Mm-hmm.
So how long from contact to reaction in the most severe instances?
It can be seconds. Let me just tell you that part of the management of food allergy for certain patients, for long story, but we actually do what we call food challenges, because sometimes we cannot tell just for the lab work or for the history if a patient has a true food allergy. So we actually have the potential in my clinic of creating anaphylaxis for a living. So I've seen people that I have anaphylaxed because that was, and it can go in seconds, like in 2 seconds. So when I'm doing this, I have, my epinephrine, beside me. And I can, just with a look at those eyes, I know it's coming. So it is true that in many patients, the interval is very short.
How many deaths do you know of that that has been caused as a result to this disease and the lack of an EpiPen?
You know, the general estimate from studies, relatively old studies, is about like 150 patients die of anaphylaxis for food every year. It's a tough call to say because many times, there are difficult studies to do. What cause? Some people fall in the street and you never know what's going to happen. But, in all honesty, is when I tell to my patients, look, it is rare because, people have this. The vast majority of patients with food allergies, if they have access to good education, and I think the awareness has increased enormously in the last 10 years. And if they have the epinephrine, the majority of these patients won't anaphylaxis, the vast majority. There is, good examples in the audience that they do. But those that anaphylaxis, if they have the epinephrine, they're good to go.
That was my lead, because you would expect then that number to increase dramatically, correct? Absent the affordability of the EpiPen.
Completely.
And so you will find people spilling all over the state, particularly youth, because they cannot afford the EpiPen.
I tell you, this is a problem that we used to think, well, with youth, particularly youth, like my pet peeve was said, well, adolescents don't want, how they are, their risky behavior. So we actually pound on them, you need to take it. Do you have it? Do you have it with you? Show me, open your pen, and open your bag. And now I'm kind of torn because that same individual, and I'm putting into his head, you need to get this medicine and you will be in charge. Now they come back to me and says, I can't afford it. And I really have no option.
And can you tell me, doctor, and thank you, can you tell me, and then I'll close my comments, of the psychological issue that you see overwhelming our youth as a result of this crisis, of this disease, and the more aggressive psychological issues because they will no longer be able to afford the EpiPen?
I think for a patient that lives with food allergies, maybe or other sources like a bee venom allergy, that's even worse because actually that bee venom takes you down in a quarter of a second. But the level of anxiety and going on to despair, the level of a lot of people have to understand the quality of life of patients at a risk of an anaphylactic reaction is severely impaired. I can't go here, I can't do that, I can't do that. I used to tell them, you can do this, and you can do that, and you can do that, provided you have your EpiPen. Now we got to go back to a state that maybe they can't leave home because they don't have this medicine that is so essential to them, and affects the family, the kid, everyone, the school. I'm sure, I've done a little bit of school health, in my time, and it's a huge problem.
Well, I'll tell you, when I attend meetings, when I go to dinner, when I go to breakfast, when I go to lunch, even when the senators meet, I'm oftentimes having to ask, what's in the food? What kind of sauce is in there? What if there's shellfish? If there's oils and things of that nature? And quite honestly, it's somewhat embarrassing, right? To have to everywhere you go in meetings have to inquire. Take time and bring the cooks over, or the chefs, or certainly don't travel internationally. It's a mess. It's a disaster, and it's something that causes psychological issues. And then to be a child, to be an adolescent, and have to have that level of responsibility is somewhat cumbersome. Would you think?
I agree. Do you have your EpiPen with you?
It's in my bag.
Let me look at it.
Yes, indeed.
You can if you have education and you have your epinephrine.
Right.
That's why we're here.
Thank
I
you.
just think to add with the school, your point is extremely important because at school, having just one EpiPen is not enough. We need to have one in the child's classroom, possibly in the cafeteria. And so when you're talking about needing multiple of these doses, and it's the astronomical cost, parents have to decide, do I give one to grandma, or do I keep one at home, or do I send it to school? And it is because the reaction happens so quickly, and they need to have it within seconds, that we can't rely on it being stored in some offices that sometimes are quite a distance from the student.
You know what I mean? Thank you, Doctor.
Thank you. So let me just, for the record, Senator Holly Mitchell joined us. I want to welcome her.
Thank you, sir.
We're in question phase right now. I wasn't sure if you had any questions you'd like to ask the panelists.
Not at this point.
Thank you.
Thank
A
you.
couple questions. Again, comment first. Thank you very much for being here. I appreciate the testimony you gave in the hearing. First question is to Ms. Kathy Owens. You had mentioned cost, and are you noticing a higher increase of students coming in now who are saying they can't afford the EpiPen as opposed to, say, years ago or decades ago?
That's exactly, as I said, we used to have 30 to 40 EpiPens in the office, not counting, then we'd have a duplicate one maybe in the cafeteria or in the classroom. In fact, this school year, we had to meet with our Department of Nursing, because parents are stating their child has this severe food allergy but no medication. And so the number of families that are unable to provide this for their child. And the problem in the school is not only is there lack of the medication, but we write a care plan when we have a medication order. So we get an order from a physician, and then we write an emergency care plan. As I said, we can designate
Right.
certain staff. Without those medication orders, staff are not being designated. And this year, one of our schools that had 45 EpiPens last year in the health office have 6 right now. And, that's just an
Right.
example of how many.
So you're definitely seeing an increase of parents' inability to bring pens or fill the
dramatic.
order because of the direct increase to the cost to
And-
that patient.
And unfortunately, I also advocated for the stock epinephrine, and as Dr. Lorette said, I feel like I'm somewhat contributing to the problem, because parents feel like, well, the school will have it,
Right.
they'll take care of it. And they need to know that, we have those children for so many hours, and we may not. That EpiPen may have been used on another student. It may not be where their child is.
Right.
That's not fair for them to release their kids to us with that.
And I
That's
appreciate
great.
your advocacy, and you mentioned that I believe you worked with Senator Huff for the introduction of that bill, and of course, it was admirable, which leads to the next question. So yes, we have albeit a very low percentage of incidents of individuals having an anaphylactic shock. Education's important because you've got to make sure that they can recognize it, but more importantly, do whatever they can to not have that shock. However, we do have various laws, not only federal but state, which is going to require this product in the school site. Because of that, and because of the fact that students aren't bringing them in because of the costs, now that burden is being passed on to our public education system. We have a public education system that's already straining with less books, less resources, less money. This is one additional cost now that's being passed on to our educational system. Do you happen to know roughly the increase or the percentage of cost to your school district as a whole because of
This
the
program.
need, because of this program?
2012, Mylan, and I'd actually had conversations with them for many years, because the cost to school districts, we've had stock epi for many years because of my situation, but we actually had to change our board policy and reduce the number, that we would only have 1 EpiPen per school because the cost. 2012, they did launch a program called EpiPen for School. It's national. They will provide them to schools for free EpiPens per school site at no cost, if you have a physician that writes the order, and you have standing orders, and you have staff that you can train. So there's several components to getting those free. It was to sunset this past year, July of 2016. I've put my order in, and I've not received mine yet, so I don't know if it's
Right.
renewable. So there is no guarantees, and the cost, even though the EpiPen itself is provided, there's no guarantee they're going to continue.
Right.
And it would cost, in our district alone, it would cost over $30,000 per year, because they have such a short shelf life. And when they talked about the vial and the syringe, in California, we cannot delegate that type of a task to an unlicensed person. And you have to understand, this child's in a severe breathing crisis, it's an emergency. Someone who's not proficient with a needle and a vial
Right.
could no way, do that and adequately administer it to a child in an emergency situation. We have to have auto injectors.
So you're saying this program is being introduced by Mylan. Do you think it's in response to the negative press that they've been getting, or is this something they've had all along to try to control costs to the various schools and the policies throughout the various states?
It happened in 2012, and I think there was a large outcry because, again, I was speaking nationally. We needed stock epinephrine, so I think the company, in good faith, decided to launch that as a program, and it's a very appreciated program. However, conversely, the price of, as you said, 2007, it was $100. Once they introduced the program, the price just seemed to double every
Right.
single year. So someone was paying for
No,
that.
I was going to tell you, when the, I have in the background where I think Governor Brown signed a bill saying that there should be epinephrine in every
2014,
school
right.
in 14.
Right.
And, I have to be honest, I know the rep of Milan. They come to my office all the time. So we work a little bit with the school district with the LAUSD. That's a million kids are in the LAUSD. And the doctor there called me and said, how are we going to pay for this? And I said, well, I don't know. Maybe call Milan. Milan has this program. And they did give all schools. And at the time, I thought, well, they're so nice. What I had known, and I learned after this debacle, is that there was a fine print. They gave every school a set of two, I think, a 0.3 and a 0.1. But there was a fine print that said you cannot buy from any other person. So I don't know for how
Right.
long, but there was a fine print, even to that generosity that I wasn't aware. I thought they were, say you're so good. It's so great that every school is going to have its thank to you, and it was a national program. And I know for a fact that we told the LAUSD doctor, call here, and she called us back and said, yeah, they're going to give me $1 million from my million schools, or whatever number of schools in the LAUSD. But there was a fine print, and as you say, I don't know if it is going to be renewable in this environment.
Yeah, unfortunately, it seemed like by doing that out of the goodwill, but they're going to pass that
Well,
on
that price
by
was-
increasing the prices somewhere else to offset their losses there. It's unfortunate. So let me again, to Ms. Owens, with regard to school, I want to emphasize on the school and the cost that we're now having with policies that the state legislature implements and the governor signs, unfunded mandates. We are mandating that you have this product, which is very important. Because we're having and requiring unfunded mandates, do you feel we should have policies to mandate that companies that provide this product provide it at a discount?
Absolutely,
Yeah.
absolutely.
Mike, please.
The cost of the cost of a child's life, and knowing that epinephrine is that 20 to 25% of children have their first reaction at school before their parents even know it. Knowing that children are in the care of school over half their waking hours, schools have to be able to provide parents that assurance that their child is safe. So not having it is it's foolish. It's the company. This was not an unaffordable product when it was first introduced at $25. That was a cost that I think school districts could have absorbed. At this point, our school district, if we were asked to have to supply the cost of the medication, they would drop the program.
Right. Okay. Thank you. I believe Senator Mitchell did have a question or comment.
Yes, I do. Thank you, Mr. Chair. I'm not sure, Ms. Owens, if in Murrieta Valley you have the same experience we have here at LA Unified or Culver City School District, where we have multiple vendors who come onto the campuses to provide after-school programs. And they're not run by the school. They're,
Right.
separate. And so do the after-school care providers have access to the EpiPen on your campus?
Well, actually, the legislation that was written, it was specific for the school campus during the school day. In fact, specifically not required to even send on field trips or off-school events. And part of that reasoning
That doesn't seem
is,
prudent.
Well, it doesn't, and we should have them, you know, it's like every single building has a fire extinguisher. When was the last time there was a fire? But you would not have a building code without a fire extinguisher, and you wouldn't have a bus without a fire extinguisher. What's the percentage of that? But we know it saves lives. But if we would take our stock epi, unless we had an unlimited supply, and I'm going to send it off with the bus, now I've just left my population of my school completely uncovered for having that. And again, the law has some restrictions on it, understandably so, that staff have to volunteer, and so we can't have someone send a medication along with anyone unless they're fully trained to understand how to administer it. Otherwise, it's useless.
So I get the field trips. Those are, in many districts, few and far between. But what percentage of your students would you say participate or attend after-school care?
Oh, well, we have not only after-school care, we have sporting events, we have you know, Girl Scouts that meet, we have the YMCA that comes in, absolutely.
So
And
good percentage of your students are in after-school care every day. Field trip
Without
is one thing,
access.
but every day on the school campus. And so as the parent, we've heard about the law. We know that there's there's access at school. And a number of parents don't often make the distinction between
Right.
the after-school care provider is a different entity. And so that's very
Well,
alarming.
And that's why that I'm here, because we have to advocate for that child's individual prescription. Children who have known allergies must have that medication with them. They must have it at the after-school program, they have to have access, because we don't have the time. With the young man, Corey, in my situation, paramedics were probably 2 to 3 minutes out. He wasn't going to make it. And I, you know, at the time I thought, well, I'll grab someone else's. And, you know, I had nurses all over the state and the nation say I never would have done that. And I said, you would have let him die? And they said, well, I wouldn't have risked my license. And I said, well, my license is not as important as a child's life. And I had no licensure issue. But it made me realize that that's how fast it can happen.
Right.
So those after-school programs those children do deserve, and that's where the cost is exorbitant and prohibitive.
Thank you.
Thank you. Let me thank both of you for your time. I appreciate it, and we're going to move on to the next panel. Just give us a couple seconds to get it set up, please. Excuse the pause between panels. We need the placards. Next, we're at the unbranded advocacy, number 4.
Thank God.
Next one. Okay, we're at item number 4, unbranded advocacy. We have Kelly Woyan-Runicki, advocate, writer, producer, and mother of 5. Boy, that's expensive.
It sure is.
That's a lot
And
of work.
busy.
What are their ages?
What are they? 16, 14, 11, 10, and 6. I always
Okay.
have to think about it when I recite it.
Well, good luck. My kids are growing up and out of the house and off the family payroll. You got a lot of years ahead of you.
I know.
Welcome, and
Thank you.
please proceed.
Thank you. Good morning, and I hope you don't mind. I'm going to read from my remarks. I literally just got off a plane, so I want to be coherent for you. Thank you for the opportunity to speak here today. My name is Kelly Runicki. I am a food allergy advocate, former Mylan spokeswoman, and the mother of 5 children. My oldest son, John, is 14 years old and has been living with life-threatening food allergies since he was a baby. If he were to accidentally ingest even trace amounts of peanuts, tree nuts, peas, legumes, or dairy, he would die within minutes. Unless, of course, he had immediate access to the only medication that would save his life, Mylan's EpiPen. I'm here today to speak to you about my role in Mylan's unbranded marketing campaigns as a former paid spokesperson. But most importantly, I'm here to speak to you as a mother who has advocated for food allergy awareness for over 12 years and with Mylan for 2 years. 2 years ago, I noticed a disturbing increase in the price of EpiPens. I personally raised my concern to Mylan at the time. The response was, "Thank you for your feedback. We are working on it." I believe they're still working on it. My focus was not profit margins, it was strictly advocacy. I learned about these most recent increases as everyone else did when they went to go fill their prescriptions. With EpiPens, as many of us here know, they expire after a year, and so typically we're not aware of the price hikes until they actually expire. And in my case, that's what happened. As an advocate, I also get emails and contacted by other parents across the country, and I was getting a lot of emails this fall saying, my EpiPens are costing $300, $600, $900. If you have 2 children, I know one family in particular, it costs them $2,400 to fill their prescriptions for school, home, camp, for 2 kids. Families cannot afford that. That's absolutely ridiculous. So had I known, even last year, that the price increase would have gone up this much, I would have spoken out much sooner. I did resign as my role as a spokeswoman almost immediately, as soon as I heard about how much the price hikes had jumped. And so for me, I feel it's important to kind of discuss my role with Mylan and what I know to be true and how I worked with them on their unbranded marketing campaigns. When I first came on board as a paid spokeswoman for Mylan Specialty, I was excited for the opportunity to reach potentially a wider audience. Food allergies was never sexy enough of a story for the media to cover unless it included a back-to-school angle or, God forbid, a death. Funding for food allergy research is much lower than other health conditions, and to this day, there's still no cure. Mylan offered the opportunity to get the message out about food allergy awareness through unbranded advocacy campaigns such as Get Schooled in Anaphylaxis. That's what I personally worked on. I was interviewed by different press and talked to audience members about Disney World, things about, and I'm sorry, to Disney World. I also worked on their Food and Wine Festival. I would do cooking demonstrations and would then talk about, how to be prepared in the case of an anaphylactic emergency. So I would talk about, be sure to have at least 2 epinephrine auto-injectors on you at all times, know your food allergy triggers, have strict avoidance. But I was never allowed to call EpiPens EpiPens, ever, not once. And if I did, I would get in trouble. And I did get in trouble. Everything was unbranded and advocacy and education based. I thought that was a good thing. But because I thought I was being an advocate, being used as a mouthpiece for food allergy awareness, but I was really just being used. Last week, Mylan CEO Heather Bresch was asked a lot of questions about her rationale for price increases, but shouldered the blame elsewhere. She said she wasn't sure about specific profit margins and deflected questions. She gave hardly any new information that might be helpful in reversing this horrific situation for consumers and families like mine. Have any of us here even heard a direct apology or statement saying, we are wrong, we are sorry, we will fix this? Mylan needs to show transparency and be accountable for how they have manipulated the very consumers who filled their pocketbooks, even as those same consumers wrestled with having the money in the first place to fill their life-saving prescriptions. A big piece of this troubling puzzle is how Mylan is a case study and how it, along with other pharma companies, use unbranded marketing campaigns to gain consumer trust and reliance, often without the consumer even knowing they were being manipulated in the first place. The approach is simple and straightforward. Educate your target audience and your target consumer about a health condition through a story that impacts emotionally without having to discuss the standard list of side effects or other specific drug information. The drug company's involvement is minimized and downplayed. Why? Because pharma companies are less popular than oil companies or lawyers, and according to a Gallup poll, hated just slightly than federal government. I apologize. Pharma companies like Mylan are business savvy enough to understand that one of the best ways to counter their lack of credibility is to align directly with the very consumers who rely on the medication they provide. Mylan dominates the epinephrine auto-injector industry. They did this by shutting out competition, working with advocacy groups to push legislation, create savvy media spots, all while quietly and systematically raising the cost of the EpiPen by double digits. As a mother of a child with food allergies, I am disgusted and saddened by this. Before I resigned from Mylan, I told executives exactly this. My responsibility is to educate the food allergy community and advocate for them. I have battled for years and often with much opposition with school districts over the issue of providing our kids who have life-threatening medical disabilities the same rights and access to health care, safety guidelines, and a free and appropriate education under the ADA umbrella. Access and affordability is critical. And actually, it's not optional for children like my son. If they don't have access to an EpiPen, they will die. It is the only device that will save our children's lives in the event of an anaphylactic emergency. And as an advocate, I tell parents to have an action plan and at least 2 epinephrine auto-injectors on them at all times, because it will take only mere minutes for death to occur without it. Yet thousands of children across our country will be forced to go to school, camps, and even in the safety of their own homes without epinephrine. And why? Because they can't afford it, even with a little $100 coupon from Mylan. I'm a single mother of 5 children who, thank God, can afford this medication for my son. However, there are countless other single parents, married parents, families, grandparents, anybody that you can think of that has food allergies, who will need to choose not to fill their prescriptions because it will cost them $300, $600, $900. If their monthly income is $800 a month, what will they do? Nothing. And what choice do they have? And soon enough, a child's life will be lost. An innocent child just like my 14-year-old son. And for what? For money. And that is something I cannot accept or comprehend, that line of thinking. And neither can the tight-knit food allergy community, which I am here to represent. Thank you.
Thank you. Do we have any questions for any of the members? Senator? No questions? I'd like to follow up with you on your statement about unbranded advocacy or advertising. First of all, I want to thank you for being here. I understand your motives because you have a cause that you believe in. And when you first were approached, I'm assuming by Mylan, or you approached Mylan, or were having those conversations, I'm assuming you felt you were doing it for a noble cause. Yes, you were paid.
Yes.
Okay. But the interesting comment is that it is not just Mylan. I think this is the playbook for pharma. And the reason why I say this is because they have the ability to market without talking about side effects like we see in TV. And that's why you were told not to use EpiPen. Well, guess what? You're going to educate the consumer about allergies, but if Mylan's the only person that sells it, they're going to benefit, okay? Tell me about your thoughts now that you've been involved with unbranded advocacy as a policy from pharmaceutical companies. Do you feel like this is something that government needs to look at under a microscope? Because, or do you feel that they're kind of skirting the laws to try to educate their product?
They are in the business to make money, and Heather Brush is the first to tell you that. She told us that. This is a loophole. This is where they are very business-minded about their approach to monopolize the market. They control the market. Why do they need to educate and advocate? They absolutely dominate it. And I found it interesting even when Auvi-Q was taken off the market a year ago because of there was some issues with the recall. Mylan was the first on the scene to distribute a press release saying, you know, we have enough for you. We will take care of you as our consumers. And I found that interesting too. I think it is a wider reaching problem about pharma companies. I think there's a lot of people in offices trying to figure out the best ways to, you know, market themselves without having any direct responsibility. And so by doing unbranding campaigning or marketing campaigns, I think that's an interesting thing that we really, as a government, need to take a very close look at, because I know how I was used. And I know at the time, I felt like truly I was doing just advocacy and awareness. And I always had a little bit of a, why did I get in trouble for saying EpiPen? Because that's what it is. That's suspect to me. So that's something that I just think, from my personal experience as somebody who is media trained personally by Mylan, I would love for the government to take a very close look at.
So let me follow up with another type of question. So I watch TV. The other day I watched the Dodgers win their division.
Go Cubs.
No, go Dodgers. Sorry. But while watching the game, or anything we watch, I watch commercial after commercial after commercial is advertising drugs. And half the time, and I'm a provider, I don't even know what the drugs do, but they tell you to go talk to your doctor. And it just seemed like there's direct marketing to the consumer. And again, they have these little, quotes that cause this, and this, et cetera. But yet when I introduced SB 1010, and there was opposition to it, and they were saying, well, we have R&D, and we have investment, and we have life-saving drugs. Yes, I agree. But here's an interesting statistic, and I'm going to get to a question I'm going to have to you, or pose to you, is that over 50% of the R&D in this country is paid for by the university systems and the government. But yet, for every dollar spent on R&D by the pharmaceutical industry, $19 is spent on marketing. So they're doing very, very well, and they're making plenty of money at the expense of the consumer and the taxpayer. Should government look at, and I know it's free speech, but look at how it's changed, should we be looking at advertising directly to consumers?
Mylan is your case study on why it's a necessity. It has to be done because over the past, actually a very short period of time, they have dominated the market. Their executives, we all know the numbers. We all know the profit margins now. A week later, when Heather was asked to disclose it, we now know how much the company's really made. That's enough for me, and it's enough for me to know that I have heard from so many parents who are having to make the choice to not fill a prescription that is irresponsible. As the company that makes, the only device that families like mine can use, there's something wrong there. Yes, they've spent a lot more money. I think there's been some research into that and how much more money has been spent in marketing campaigns. The thing is that with unbranded marketing campaigns, you get to tug at the heartstrings. You get to, involve your consumer emotionally and let them know that you can trust them. And then at the end of that marketing campaign or that commercial, they'll refer you to their website for additional information where you can download, helpful resources or download the copay, and hopefully that copay will work for you. A lot of times it doesn't, depending on your insurance plan or if you have insurance at all. There's such a lack of responsibility on behalf of Mylan or other pharma companies. Like, if you know that your consumer is struggling to afford this, and honestly, it doesn't even take a Rhodes Scholar to look at me in the face and say, well, it's $600 for one prescription. I hope you can afford that. No, that's just, it's just very simple to me and straightforward that we need to pay more attention to how they did it.
Yes, Senator Mitchell.
I was looking through my email, and I can't find it, of course. And it's really, I guess, directed to you, Senator Hernandez. I hear you, and I get the challenge with direct advertising, but there's been a series of articles that just ran this week that talked about African American women specifically and our rate of access to stroke recovery medications in a short enough time frame right after having the stroke to make the difference compared to other populations. And as a former health advocate, I really struggle with if certain communities, or if all communities, but certainly underrepresented communities, underrepresented in terms of access and equity in provision of healthcare services, don't advocate for ourselves and know what to ask for, then that disparity could broaden. And so that, I think there's a challenge and a real balancing act there. Today was my first time I've heard the term unbranded advocacy. And while I get and feel for you in terms of having felt that you were taken advantage of, I also get the benefit of conditions that aren't sexy, the media's not going to pick up, how the general public is informed and educated, and thereby empowered to advocate for themselves. And so it's a real balancing act. I know sometimes when government gets involved, we can be very strident and get very prescriptive in terms of what you can and can't do. But how does that then tie her hands in terms of the good you perhaps did in your cooking demonstrations to really empower parents to know that this doesn't have to be a death sentence, and what role you can play to make this manageable in the life of your child. So it's not a specific question, but just one of those, how do we create this sense of balance?
And I appreciate that. And I'm just posing the question because, yes, there's direct consumer access information, but maybe we should frame it in PSAs. Maybe we should put more money in community services. Maybe we should educate providers who practice in underserved communities where there's a higher incidence of African American women that say, make sure that they understand, but do it in a positive but prudent way that's not going commercialize it. I mean, healthcare has changed over the decades that, you see the cost of LASIK vision surgery advertised when I'm driving down the freeway. I mean, I'm just posing some questions, and when is it the responsibility of government to interject, and especially when we're asking the consumer, you have to buy this product. You have to buy health insurance. You have no choice. That's the question.
I'd like to add to that. Let's talk about the FDA, and how about why was that question so difficult to answer about what else is in the queue, in terms of other competition. It's a question that needs to be answered, and I would love to know the relationships that are there in place with the FDA and pharma companies like Mylan. These are areas that we can look at to see where the cracks started forming, so that we can ensure that families like mine and consumers who, when you're talking about a medication that literally means life or death, it's a very different conversation than maybe other types of medications. So I think it's a priority that we have to look at all angles on how did this happen so we can fix it as soon as possible and stop the bleeding.
Right. Let me see no further questions. I want to thank you for being here. We'll get set up for the next presenter. Thank you very much. So we're at item number 5, response. We've invited Heather Brush, CEO of Mylan, was invited. We have actually opened up the invitation to a representative from Mylan. Seeing no one to show up, just wanted to let everyone know that there has been an invitation for a response, and no one was sent. There was a letter sent, which we can provide later. Put up the next speaker, please. We gave her a name tag.
That's terrible.
Okay, we're going to move on to item number 6, pulling it all together. We have 2 speakers. We have Lisa Gill, Deputy Editor, Consumer Reports, Best Buy Drugs. We have Donna Goldman, Director, USC, Leonard D. Schaefer, Center for Health Policy and Economics. Good afternoon. Thank you. And we'll start off with Lisa. Please proceed.
Oh, great. Thank you so much today for inviting Consumer Reports senators, and we appreciate being here and being a part of this discussion, so thank you so much. I'm here today in the capacity of a journalist. I am the deputy editor for Consumer Reports Best Buy Drugs. That is a 10-year-old program dedicated to looking at the effectiveness, the safety, and the cost of medications. And in regards to EpiPens, we have written nearly a dozen stories on this topic. We started receiving, we have either through Facebook or other sort of social media means, even emails we receive from consumers. We got a flood of emails over the last year asking about how can I lower my EpiPen costs? It's bankrupting our family. We learned a couple of things, actually some very interesting things as we took a deeper dive into this issue, and I wanted to share those today. A couple things. One is that there are some families, as mentioned earlier by Senator Hernandez, they have health insurance, but the deductible is so high, $5,000, $10,000, $15,000, that they have to pay out of pocket before their insurance kicks in, which means in some cases they're paying the full price or nearly the full price of any medication, including EpiPens. It becomes cost prohibitive, and many families just decide to go and pay cash instead, which they might be able to get a discount on, instead of paying, through their insurance company. That is a problem. We also talked to patients who were neither an EpiPen nor an alternative were even covered, which is frightening as well. So you have another access issue there. The third thing is that one of our editors really late one night while trying to find an alternative discovered something called generic Adrenaclick. Now, it was mentioned earlier that epinephrine is a nearly 100-year-old medication. It is literally pennies to make, but the actual mechanism, the auto injector is a patented, unique technology, and it is true Mylan is the only company that makes that. But this other company, generic Adrenaclick, the auto injector is a different mechanism, but the only difference is that you remove a second cap. It's really no big deal. We found it, instead of having to pay $600 or $700 potentially out of pocket for EpiPens, we found you could pay $144 for generic Adrenaclick if you used a coupon and you went to Walmart. So that was very useful for us in many of our stories to explain that EpiPen was not the only game in town. And to the comment earlier about direct-to-consumer advertising, EpiPen has really become a household name. It's like Kleenex. Through a very savvy sort of series of marketing campaigns, billions of dollars, or at least $1 billion spent really trying to be out in front. And that's why you've never probably heard of Adrenaclick or generic Adrenaclick. We've been dedicated to this issue, not just in EpiPens, but also looking at the problem of the cost of high medication costs, and particularly out of pocket. We really started to focus on what is the problem, why are consumers spending so much money? And I want to share some other sort of more broad statistics that to us were rather alarming. As part of our Best Buy Drugs program, every year we do a nationally representative telephone survey of adult Americans who take a medication. And it's just good to know that in thinking about this conversation and Mylan, this problem is widespread. And it's in a couple of ways. Almost half of all adult Americans take at least one medication. So it's almost about 45%, and that's on a regular basis. But it's not just one. The average is 4, almost 5. We also asked people just a few months ago, we said, hey, when you went to the pharmacy and you went to fill a prescription, did the price of any of your medications go up? 1/3 of people said yes. And I have in my notes here, Angela Chen. I've underscored Angela's testimony here because she talked about the unpredictable nature of when she went to go fill her EpiPen prescription. She was one of 33 million Americans just in the last 12 months whose prescription drug costs that they paid out of pocket went up. The average price, the increase that people experienced was somewhere around $60 or $70. We saw people that's a lot of money. That's the average. We saw some prescriptions that people told us they went up 100, 500, 1,000 or more. Our estimate based on this national survey is that in the last 12 months, 33 million adult Americans, for a drug they take all the time, not something special, spent over $1 billion out of their wallets because coverage was not good, because the price had gone up, because they had a high deductible plan. It's not always clear why, but we know that high drug costs are impacting people. The reason we care about it, and the reason I think this committee cares about it, is because when that happens, we can see there is a negative effect on consumers and household finances. So we ask people, hey, when you had to fill this prescription, the price went up. Did anything change for you? It turns out people had to spend less money on groceries. That's scary. They had to use their credit cards more often to pay for just regular, utility bills. They had trouble paying for some of their major bills, like credit card bills, auto loans, mortgages even. There's a real and lasting effect when people cannot afford their medications, and that's when they fill the prescription. The other thing that we learned is that when the price is too high, they don't fill the prescription. And if they do it, they don't take the medication correctly. They may share prescriptions when they're not supposed to. It turns into a very negative and bad situation. It's very challenging. We wrote recently a huge feature story for Consumer Reports magazine, and it was about this topic in general. Mylan is not alone. EpiPen is just by far the most recent example. You can see the price of rising drug costs across old generic drugs, like hydroxychloroquine, is one we wrote about in the story for rheumatoid arthritis, pennies on the dollar to make. Now it costs several $100s a month for a patient. We saw it happen with drugs like insulin and asthma inhalers. We've seen it even happen with Daraprim is the other best example for people with HIV/AIDS. All of this is to underscore that for most people who, if you receive your insurance through your employer, so the commercial payer market, there's no rule, there's no law, there's no regulation. There is nothing that prohibits both the setting of very high prices or the raising of those prices. They can raise them whatever they want. That's why Mylan has been able to do this. That is concerning, and the lack of consumer protections around the consumer market are what has concerned Consumers Union, the advocacy arm of Consumer Reports, the most. I want to share, just in my closing remarks here, there were 5 fixes that we had suggested in our story, and they might be worth considering for the state of California. First off, the first one for us was limiting out-of-pocket costs for consumers. Now, the state of California has been, you've been a pioneer in this, and you've passed this legislation already, and we've urged it in other states to adopt as well to help people so you don't go broke every month trying to fill a prescription. The other thing is we've asked the FDA to step up their approval of generic medications. There has been a backlog. The office is overwhelmed. FDA has staffed up, but approving more generic applications would be essential. We've also asked Health and Human Services to exercise their march-in rights, which is a little-known clause that would allow HHS for what are considered essential medications to literally step in and start making the drug or mandate that another drug like Daraprim be made by somebody else. The state of California might be able to do that as well. We have also suggested, so I don't know if many people realize this, but if you order a drug from Canada right now, it is technically illegal. Although the FDA says they will look away, it is still an illegal practice. We have suggested that the FDA remove that and that we make it legal and allow Americans to shop outside of the United States borders and do it in a safe way. The fifth and final thing is allowing, this is a bizarre thing, but allowing pharmacists to actually offer you a lower price when a price is available. We learned through Costco. We do a lot of secret shopper programs. We do all sorts of things to try to understand what consumers are experiencing at the pharmacy counter. And we learned that a pharmacist, if you have Medicare Part D insurance, and we think this may be true for Obamacare insurance and commercial insurance, but it's hard to know this because there's no transparency in this market. A pharmacist cannot offer a patient the lower price if it's a cash price. So your insurance copay may actually be higher than what the actual cash price sitting in their computer is. It is a clause that when they sign contracts. So we've called for the removal of what we've called the gag order on pharmacists. But in closing, I just want to say thank you for raising this important issue. The EpiPen problem, unfortunately, by all the investigation that we've done, all the interviews and research, this is not going to go away. This isn't going to stop. We do not foresee, unless there is government interaction or a government sort of intervention, rather, this problem stopping. And it's very concerning for Americans. Thank you.
Thank you. We're going to move on to Dana Goldman, Director USC, Leonard Schaefer, Center of Health Policy and Economics. Thank you and welcome.
Yeah, thank you very much, Mr. Chairman and Senators Mitchell and Hall. I want to make clear I'm in the Mylan chair, but I'm not representing Mylan. So, I think we all know that pharmaceuticals account for a broad fraction of healthcare spending. It's about $300 billion, which is about 12% of personal health care spending. And the point was made earlier by Senators Mitchell and Hall that for the millions of Californians who have chronic illnesses, especially our most vulnerable residents with access problems, prescription drugs provide a vital lifeline to forestall disease, prevent mortality, and reduce morbidity. And generics are a really vital component of that. 88% of the prescriptions today are generic prescriptions, but they're only 28% of the prescription drug costs. And it's important, we tend to have hearings when something goes wrong, but it's important to note sometimes it goes right. The General Accounting Office just did a study this year of the generics market, and what they found is that on average, prices have declined 60% over the last 5 years. However, what they found is that for 300 of these generics, they had what the GAO termed extraordinary price increases. So the challenge for you as legislators and policymakers is how do we make sure the part of the market that's functioning well continues to work, whereas while we deal with the failures that these extraordinary price increases. And I think Consumer Reports and I are very close in this regard. There's an analogy with electricity. In California, we have a utility, the Public Utilities Commission, which is designed to ensure that all Californians have access to safe, reliable service. We don't have a similar regulation for drugs. And yet it seems quite obvious that we should ensure safe and reliable service when it comes to pharmaceuticals. And in the case of the EpiPen, we heard a lot about how it's the only medication in the drug market. Well, I don't think that's a failure of Mylan, that's a failure of the regulation. We had opportunities to ensure adequate supply, and you mentioned some of the alternatives here, and we allowed some suppliers to get off the market. The role of regulation is to make sure that we have adequate competition so that we can ensure access to these vital drugs. But I want to say one thing I've been talking about generics, but I want to say something about brand drugs. Okay, and there's an important distinction to be made. When we think of generics, we're thinking the analogy is electricity. But when we talk about new, innovative, patented drugs, we're talking about something that is more like what Apple does. It's someone who's invested in R&D and come up with a product, and they need to make a rate of return to reward that. And I think if you think about, for example, HIV, and you rewind 20 years to maybe the late 80s, and you, like me, may have been in Los Angeles at that time, and you remember when Magic Johnson announced he was HIV positive. And I remember watching his press conference and thinking to myself that this is the last I'm going to see of Magic Johnson. Well, it turns out Magic Johnson was able to be treated with a new therapy that came on the market, highly active antiretroviral therapy. And now Magic Johnson is one of our, well, in the ultimate of ironies, he owns the Dodgers. So, but the point is that even with his enormous wealth, prior to the introduction of those antiretrovirals, he had no access to care. And it was only the innovation that he had access to that allowed him us to transform HIV from a death sentence to a chronic illness. And now we can treat HIV for $1 a day. And we're actually treating HIV in Africa as a result. So I think the important point is we want to make sure that we reward the innovators and make sure they continue to come to market. And my concern, part of what I heard today is, maybe the government should be doing this. And, developing pharmaceuticals is expensive and messy business. In my experience as a researcher funded by the NIH is that people don't always want to roll up their sleeves. And we've got some remarkable innovators in California who are willing to roll up their sleeves and do the clinical trials. And you mentioned there's a partnership between these universities and the private sector. So we got to make sure that we reward that innovation. So to summarize, I think clearly we need to ensure generous coverage of the most effective medications and do so at a transparent price. People have to know how much they're going to cost. But I think regulating the provision of generics to ensure a safe and reliable supply as we do, and a fair rate of return like we do for electricity would be an important step in this direction. But the third point is that we have to ensure access to future innovation, and that's going to require some recognition that if someone develops an innovative drug, they're going to charge a lot for it. But the point is, we want prices to reflect value, not someone's manipulation of the market. Thank you.
Thank you. Any questions from any of the members? Senator Mitchell?
Yes, please. Thank you, sir. Ms. Gill, I listened very closely to your 5 points, and I was wondering, we don't have anyone here from California Department of Healthcare Services or the Office of Managed Care, but I was wondering if at the state level, CDHS has these march-in rights that you talked about at the federal level.
To the best of my knowledge, it's at the federal level. And I will say, too, that at HHS, when we have signed on, Consumers Union has signed on to different congressional letters asking for march-in rights to be used, particularly in critical situations and in cases where there might be a supply shortage or the cost is just, there's been basically a monopoly. HHS has been reluctant. They don't feel they have the real authority, and there seems to be a little bit of confusion over what margin rights really are. But there's a huge reluctance. I don't think that means that advocacy groups should stop. It is a mechanism, and it's an important mechanism, and it does exist. And it would at least be, it doesn't solve the problem, but it would at least be sort of like an airbag, in a car. I mean, it would give us one type of emergency mechanism.
And with regard to the gag order that you also talked about, I also wonder, when I think about the state of California and what we pay for between, PERS, our retirees, health benefits, all state employees, Medi-Cal, covered California. We're a big purchaser when you really think about it. And so even with regard to the gag order, I'm looking at that as both a health committee member and a budget committee member, Dr. Hernandez. Is there a way the state can then give those directives to pharmacists that if the cash cost comes in beneath your copay as a PERS retiree benefit, so can the state play a role there?
Oh, I think absolutely. I would imagine it would entail looking very closely at the contracts between the state and the pharmacy benefit managers and the contracts between the pharmacy benefit managers and pharmacists and the pharmacies and the pharmacy networks, and if you have preferred networks or other sort of distribution mechanisms. It's interesting. The clause doesn't. Our term is gag order, but there's a sort of like an insider industry term about. It's escaping me at the moment. I'll think of it in a second. But it requires basically like an expert level person to go through and dig through the contracts. And part of I would argue the lack of transparency in these contracts and agreements are what drive up costs unwittingly. You don't realize. I think it's true for employers too. The Consumers Union has testified with the Department of Labor about transparency problems between the contracts that pharmacy benefit managers offer to employers in the employer market. There's no transparency. No one knows any of this.
Interesting. Thank you.
So I'd like to just kind of follow up on the comments that Dana Goldman, which you'd said with regard to rewarding innovators. I agree. I totally agree that we have some incredible drugs that are in the market, but we also have to have that policy balance where we're now, as I mentioned in my opening comments, we're requiring that consumers purchase this product. Where is that balance? And I appreciate your comment about generic drugs and also the fact that we need to have competition. How do we address that when we want to reward innovators, increase competition? Tell me how we go about that, and how does government facilitate that?
Sure. I think there are several ways to do that. The first is, and some of this can be done at the state level, but let me start at the broader level. there are tricks that companies may use to extend their patent life, and I'll use that term euphemistically. But there's a lot that gets done to ensure that generics don't enter the market after we've rewarded the innovators. And I think the time is ripe, actually, to go to these innovating companies and say, look, we want to strike a deal. We need to get rid of some of these tricks, but you need to agree to that, and in return, we recognize that you need to get some rewards. So I think there would be an opportunity to start saying early access to generics would be one step in doing that. Now, the Hep C example is instructive, and you brought it up earlier, because Hep C was quite expensive. But interestingly, new competition came on the market very quickly for Sovaldi, and actually the prices have declined about 50% already. And so I do think there is the ability of the market, if the FDA takes into account the fact that sometimes it's not just about efficacy, it's about making sure we get competitors onto the market so that prices will fall, then we can ensure the rewards. Now, and then the third part is, and I'll come back to the Sovaldi example. It's a case where the nature of the contract completely misaligns incentives. And what I mean by that is the health insurer and the Medi-Cal, for example, and this is where, and the correctional facilities are being asked to pay quite a bit up front. And there's no way they say that they can afford to do that, and I think there's a lot of evidence for why that would be. However, there is an opportunity to say, look, if we work together in California to eliminate Hep C, because we actually have the possibility to completely eradicate this disease, and said to the company, we'll give you some back-end rewards if we can work together to do this. So we got rid of the upfront costs and came up with a deal on the back end, and actually the state will save money because they're doing fewer transplants, and then there is an opportunity to spread out these costs. When I buy my house, I get a lot of enjoyment for the rest of my life, and I buy a mortgage that goes 30 years. We need to, when you eliminate a disease, it's not just the current population that benefits, it's all future Californians. Someone mentioned, I think, smallpox or polio earlier. Yes. We don't worry about polio, we're getting some benefits. So if we could spread out the costs, then and design deals, then we'd have a much better opportunity. I'm sorry I went on so long.
No. And I agree, and I don't have any disagreement with that, but the dilemma is, somebody like Sovaldi, who makes Sovaldi, I don't know if they're willing to have those conversations. And I don't know if they're willing to have those conversations because they know they can make a significant amount of money based on what they can set the price at. But I also believe that there's a social responsibility to a company like that. Okay, well, instead of, $1,000 a pill, make it $100 a pill, but let's treat everybody in the state of California or the whole country, eradicate Hep C, and they'll still do very, very well. But I don't know if they're willing to have those types of conversation for the social responsibility as well, Yes.
Oh, I would suggest looking for a trusted Canadian partner. And even if it's a mechanism to, as a negotiating tactic, but how much the United States pays, and I don't know how much the state of California pays for these very expensive medications, but if you look to the north, it is substantially lower, and it's true with EpiPens as well. It's true with all kinds of drugs. Right?
So I think the net effect of, if let's say we had large-scale reimportation from Canada, the reality is the net effect of that is Canadians would not get medications anymore because they would stop supplying the drug. We talked about Mylan, they respond to incentives. So our net effect will be that our neighbors won't get access to prescription drugs. Right. I don't think that's a solution in fact, we have to think about that. The question is, and actually you asked, would Gilead Sciences be willing to do that? Now we know Gilead is giving away the drug at a much lower rate overseas and helping countries like Egypt, which have a huge HCV problem. And people say, why why do we pay so much? Well, the answer to that is a complicated one, but it basically is, malaria kills 500,000 people a year, but no one, worldwide, but no one is out there developing new anti-malarials. It took a philanthropist, Bill Gates, investing to actually do this. And the reason is there was no money in anti-malarials. And so we are paying a lot for our drugs, but what we're getting is a lot of research into Alzheimer's, which is a social epidemic that we need to deal with, a lot of research into cancer and the like. And so the challenge for us is we could come in and say, look, we don't want you to get paid, but the reality, I, for example, got into this area of research 20 years ago when I was diagnosed with type 1 diabetes. And I said, what's it going to take for this to be a cure? And my doctor said, in 20 years, we'll have a cure for diabetes.
And that still hasn't happened.
And we haven't,
That's not
exactly. And actually, so I would say the real challenge, though, is actually we have a system where pharmaceutical manufacturers get paid for coming up with treatments, not cures. Right. Like, it's in no one's interest to come up with a cure for diabetes right now, even though it's a social scourge, because you'd only get paid once. And I would willingly pay $100,000, to know that there'd be a cure for my kids who are at high risk of diabetes. But imagine if my concern is someone comes up with a cure for diabetes, and they price it at $100,000, and then people say, how can you prevent them from access? My point is, when there isn't something, the price is infinite. No matter, Magic Johnson couldn't, without the innovation, you can't get access to it. And we need to figure out how to reward it.
And I don't disagree that we shouldn't have innovation. I don't agree that we shouldn't reward the innovators. But let's go back to Gilead as well. For an example, they purchased that product from a company that had already had the patent. I think it was $18 billion, $19 billion, under $20 billion. Within their first year, they not only made their return on investment, but they made an excessive profit. In the state of California alone, we had to do a budgetary augmentation for one drug of $340 million for a year and a half, and we're paying in the billions of dollars. So they're making plenty of money. And the reason why I say that I don't know if the pharmaceutical industry is willing to have that conversation, I'm going to give you an example. Last year when we introduced 1010, which was a very, very modest approach, just pure transparency, we had a stakeholder hearing, and we invited all parties in, support, oppose. We asked pharmaceutical industry to come in. They all showed up, filled the room. I asked, are we willing to have a conversation? How do we address this problem in this state for our consumers? It was like hearing crickets. The only thing I ever heard was them testifying in committee and how well and how important they are and the innovators and what they bring to the market, but aren't willing to have a conversation of solving the problem. So I believe unless we stand up as a state legislature or as a government, we need to force them to have that conversation.
I think what I would say to that is, and first of all, I agree with everything you said, and my concern is I want to talk about the drugs that we pay a lot and they don't do anything. That's where I think the real waste is. There are a lot of drugs that are expensive and aren't innovative, and we're wasting a lot of money on those, and I think they're getting the wrong market signal that if you continue to have marginal improvement in outcomes, you'll still get paid a lot of money. And actually, I think that's an area that's more productive. The problem is our entire health system does not reward prevention of disease the way it should, and it rewards treatment of disease, and that completely skews the perspective.
And I think we need to change the delta, whether it's providers, we have to look at how we incentivize to keep people healthy as opposed to treating a disease. But unfortunately, the health system we live in is a for-profit, and you're dealing with entities that will profit immensely. Yes.
I just want to say, we mentioned a minute ago that drug pricing in the United States is complicated. It's not complicated. There literally is no rule, law, or regulation that stops setting a very high price or raising it to almost, and except for under the Medicaid program, they can raise it whatever they want, whether the drug works or not. There are no price controls in this country. And in other countries like Egypt and Canada and Mexico and New Zealand, there are price controls. And it allows those communities, those countries to have a more controlled drug spend. In the absence of that, you're going to have 1 million of these hearings. There'll be there's no magic bullet to get at it in a way that will satisfy really anybody. And until then, we are going to sit here and say, well, I agree. I don't think re-importing from Canada is the answer, but for the state of California, it might be a threat that you at least say, well, we're exploring it because the price you're offering, on this product. I mean, think about globalization. For any other product, globalization is what has created the sort of the large scale economy that we have now. Why would you not look at what other countries are paying? I think it's an essential part of that discussion. We explore it only in terms of the individual. So right now, we've said, look, if you can't afford something, we can't tell you as an organization that it's a good idea, but it's something we're asking, and I think I wouldn't leave it out of the conversation.
Go ahead, one more comment, then we're gonna see no other
Well, I was just
questions,
going to
and
say,
we'll just
so the
close.
answer, coming back to your answer, how would we do it? I think we need to get the companies in a room and say, rather than charging upfront for what you consider an innovative drug, we'll make a social pact with you, which is that if we see Hep C eliminated in California and eliminated in our prisons and improvement in the number of transplants, we'll share the savings with you. But I think what the companies will tell you is that there are rules like Medicaid best price and FDA rules that limit them from doing that, and that's where maybe you can work together to solve it.
Well, I'm always willing to have that conversation. Unfortunately, it seemed like the pharmaceutical industry is not willing to have that with me. They just seem to rather spend more money on lobbying to kill bills rather than solve a problem.
That always
Anyway.
seems easier.
Anyway, so I want to thank you for your presentation. We are now going to move on to public comment. If there's anybody that has any public comment, we have a microphone up here. Please state your name.
And Mr. Chairman, after public comment, I wonder if you wouldn't mind, since there was no representative here from Milan, if we could just read into the record the few questions we may have had from a
Sure.
representative, so it's a part of the body of our.
By all means. Yes, public comment, state your name.
Hi, good afternoon. My name is Maribel Castillon, and I am a public health nurse for the Child Health and Disability Prevention Program here in LA County. I'm also a member of SEIU Nurse Alliance of California and represent 35,000 nurses statewide. Thank you, Senator Hernandez, Senator Hill, and Senator Mitchell for your leadership. This issue is important to me because the 877 medical clinics that participate in CHDP in LA County are required to have epinephrine in their offices in case of an anaphylactic shock after immunizations are given. As Senator Hill mentioned earlier, there are many doctors who are choosing not to serve low-income patients because of the current reimbursement rates they receive. I am concerned that a higher cost of the EpiPen will discourage more doctors from being CHDP providers, which directly affects the services being provided to thousands of vulnerable children and youth in our county and our state. When we talk about the burden placed on health plans and government purchasers by drug companies price gouging, we need to remember that workers bear a disproportionate burden of increasing healthcare costs. As a patient and health advocate, I urge the legislature to continue to demand greater transparency on prescription drug pricing. Thank you.
Thank you. Anyone else? Public comment?
Good afternoon. My name is Pilar Schiavo. I'm from California Nurses Association. We want to thank Senator Hernandez and Mitchell and Hall for having this hearing today and taking leadership on this issue, which is something that nurses care very much about. Nurses hear stories every day of patients who cannot afford their medication, whether it be the EpiPen, whether it be an inhaler that, a nurse just yesterday was telling me about a single mom who couldn't afford the inhaler for her child, and because she had to pay rent, she had to pay for gas. And so, parents shouldn't be in these situations. No one should be in the situation where they have to choose between the basic needs for your life and being able to save your child or yourself. And the reality is, I know there's just a lot of conversation about, and your comments, Senator Hernandez, about pharma being willing to have this conversation. And I think your last comment was the most accurate, that they're more interested in paying for lobbying to kill any efforts at the most mild transparency bills than actually having this conversation. And the truth is that pharma is making tons of money. They make more money than the oil and gas industry. They are not hurting. Their innovation, quote unquote, is grandly being rewarded. That's not a problem. The problem is that pharma is greedy. And the problem is that they care more about their shareholders and their profits than actually making sure that people have the medication that they need to save their lives. We're talking about insulin for diabetics. Nurses are seeing more and more that patients, instead of taking their full dose of insulin, are taking lesser doses because they can't afford it. That's actually killing their internal organs. They're in the process of slowly damaging their internal organs. These are the kinds of choices that people are taking all the time, and it's not limited to the EpiPen. It's all of the pharmaceuticals, and we're seeing the price of generics going up too. And so I think, the final discussion there about really cost controls is the most important thing, that we can do as the government. We know that I think just today an article came out talking about the UK pays $69 for an EpiPen. And it's not because they're generous, the drug companies are generous there, is because the government has controls on the costs. In Finland, the EpiPen is free. Until we get to a system of universal health care and single payer, which is really where we need to get as nurses, we believe, we have to be able to put these kinds of price controls in place to be able to secure the medications that people need to save their lives. Right now, something that we think is exciting is that there's an opportunity for California to do this with Prop 61. Proposition 61 would require that the state of California get the same price as the Veterans Administration, which is 20 to 40% less than most consumers pay for medication. This is an opportunity that we can actually put that kind of price control into place for the state of California and save the state $1.4 billion a year. So this is a huge cost savings. And one other thing I just wanted to point out, because we're talking about gag orders, the state of California, you can actually do something about this because your own benefit negotiators sign gag orders. So you have benefit negotiators that sign gag orders and work in the different regions. They can't even talk to each other within the state system from the different regions to share what the cost of medications are. So this is happening right here, in the state of California within our own system. Pharma will go to no ends to be able to gag people and keep their pricing secret. Fortunately, we do know what the VA prices are, and they're significantly less. So we hope that, you all will join and support that, and also folks in this room, if you're interested, I have information about supporting Prop 61. Thank you.
Thank you.
Good morning, Geneviève Clavrol. I was a little bit concerned about the EpiPen because nobody talked about angioedema, which is also a life-threatening disease where you need to use the EpiPen, and that's a big issue. But I think the issue of insulin is even bigger. The price has skyrocketed. Insulin patent was paid $1 for the insulin. Was discovered years and years ago, but every year the price go up. And I never realized it was totally affected by the stock market. Depending on the day you buy your Lantus or your Humalog, you pay a different price. You pay a totally different copay. So I think that needs to be looked at and try to stabilize the price. And I think in last year, I was in a donut hole on January 2nd because of my insulin cost. This year, luckily enough, I have a different company, Humana, who pay for the insulin. And I was only in a donut hole in April. But that's what we have to look at, because it doesn't matter what kind of insurance you have, depending on your drug. To be in a donut hole on January 2nd is pretty bad. And I'm glad to see you getting involved in price costing, because I think you probably could do something.
Thank you. Seeing no other public comment, Senator Mitchell, you had any questions that you'd like to pose to Mylan at this time?
Well, thank you very much. I noticed that you did receive a letter from Mylan. Did you talk about that at the top of your hearing at all? Okay. And so, I'm really sorry they aren't here, because I would really be interested in probing and asking follow-up questions to the comments they made, that they claimed that the price increase, was spread out over a 9-year period. They're attempting to justify through the wholesale acquisition costs how little, relatively speaking, the profit is they make on this new increase. So like I said, I'm sorry they're not here, because I'm very curious. I think it's important. I appreciate you convening this hearing. The testimony we heard today was quite sobering. And I guess for me, understanding, as the Senate committee analysis stated, that the drug itself is extremely affordable. The cost comes from the injector. I know the patent is valid until 2025. And just wondering, if there are other companies who are going to create other injectors, so there'll be some more competition in the market, since that seems to be the crux of the issue. Just how can Californians expect to experience some relief? My other questions really follow along, again, staying in my lane as a California policymaker, and looking at Medi-Cal, Covered California, if these are additional costs that we should expect to see in our state budget negotiations next year, if they are TAR, if they're automatically covered under these plans. And I think the broader issue that you and I and our colleagues in the legislature and budget committee will have to continue to confront is this issue gained headlines. We're having the conversation today. But as you and I know, there are Californians whose health and vitality is compromised every day because of budget cuts and public policy decisions we've been forced to make over the years. And really wanting to step back and have a broad conversation about what appropriate investments we must make in our budget across the board in terms of access to all various kinds of health products and health services. And so while this is critical, the percentage of children in school who have food allergies, who rely on this, again, I want to remind us that we've got to look at all of the issues, again, in our lane as state policymakers, that we've got to figure out how to invest in. Figuring out how to create this balance between the free market and encouraging pharmaceutical companies to continue to invest in R&D to make these life-saving medications available is important. But we can't continue to be robbed. And this is highway robbery. And what makes it now sexy, where food allergies historically haven't been, is recognizing that it is in a moment's time, life or death decision around access. And I think I appreciate hearing from everybody today. It's clearly an issue that won't go away, and I hope that you will continue to drive this train as the able conductor that you are, to continue to create opportunities for us to talk about it and see clarity as purchasers and our role in providing access and protecting residents in the state of California.
Thank you very much, Senator Mitchell. I'll just close with this. I definitely will continue to drive this train. This is something I think is very, very, very important. I have some concerns, and I was frustrated that a representative from Mylan wasn't here as well to answer any of the questions that you posed. And I think I'll just close with this, and I think this kind of will bring it back, encapsulate what the conversations we've had today. So I try to take advantage and visit my parents as much as I can. I don't see them that often. They're in their mid to late 80s. So yesterday, my wife, and myself, and my mom had lunch. And I'm always concerned about my dad, who has diabetes. And I always ask her, how's Dad doing? Is he taking his medication? How are you doing? You taking your medication? Didn't even think about talking about drug prices. These are individuals who've worked their whole life, retired, Medicare, savings, a home, and they did everything right. And my mom said, I went to the doctor, but I'm frustrated because our drugs went up, and I have to go ask for free samples. And it kind of alarmed me. I go, really? And she said, yeah. And I go, does Dad ever go without his medications? Oh, yeah, he does it all the time. And these are my parents. And I just realized that they go without their medications because it's gone up. And if they can't afford it, what does that say about residents of this state and the rest of the country? Something's wrong and something needs to be done. So believe me, this is one of many hearings that we're going to have. And I have committed my last 2 years in the legislature to address the issue, and I will be taking on very strongly. So looking forward to having that conversation with you and the pharmaceutical industry. With that, seeing no other comment, this hearing is adjourned, and we will convene at the next one. Thank you.